for occlusal index, which means between 1 and 2, this means it's a patient. So I exclude medical reasons by interdisciplinary communication and examination. This means this is occlusion dictated TMD patient. Clear diagnosis. Clear diagnosis. She has malocclusion, she has signs and symptoms, and she has no medical problems. We need to treat. We must treat this patient. Okay? But to treat this patient, because long history, 2 times orthodontic treatment, spaces don't look good. This is what we need to do. We will demonstrate for making a good treatment plan. This is GPS. This is our GPS. This way we install. Would you accept today new car without GPS? Would you buy a car without GPS? Would you accept new car without GPS? Without your cell phone? No, you wouldn't. Nobody would. Nobody would. Why not give this to patient? We must do that. And after this examination, you can say if this is necessary. Yeah? So, and this consists of, we always do a photo documentation. Not 100% necessary, but makes things easy, and it's good for documentation, even from legal reasons. Especially in Germany right now, very many people going to the lawyer and suing dentists. If you can show this is starting situation, you are on the safe side. Yeah. Then we need true hinge axis face bone and condylographic tracing. What I said before, I need to make sure, is there already compromised TMJ position, or can I use ICP in this patient? Yeah. This is the term in English-speaking literature. It's called CR, centric relation. In Vienna, we call it reference position. It's physiologic reference position is the same as CR. But if you have problem here, deviation, reference position is not physiologic. This is why we prefer to use the term reference position. Centric relation, CR, is implicating healthy joint. At this point of time, we don't know. This is why we have to be careful. Okay? Always, we're using, in any patient that has TMD problem, lateral cephalometrics, because I need to know about skeletal parameter of the patient and combine it with my information about occlusion. Of course, we do a panoramic X-ray. Very modern, you could take CBCT scan now and have everything in one. We must have the mounted casts. And then the next step, okay, impressions, this is clear. Next step is condylographic tracing. We will show later, I briefly go through with you. We need those preparations. This is the so-called functional occlusal clutch. This is attached, it's a paraocclusal clutch. It's attached to the labial surfaces of lower teeth. And we have this one here. Stays only for 2 weeks in the patient. And we put it and fix it to the jaw. So every movement that patient does, this pin does. And we can trace this. And this is one-to-one. This thing is moving, and we can calculate the joint movement on both sides. We will show later. Then, this is classical registration of RP, centric relation taking, double light plate. This is very simple, but very precise. Wax is the most precise material that we have for intraoral application. Still, very old-fashioned, but very good. Yeah, we can maybe discuss later if somebody is of different opinion. And we need a clutch for the upper face bow. Later on, we are transferring upper model first to articulator, like every face bow system does. Okay? So, this is the way how to do. Make the clutch. Of course, periodontal examination, we don't have to go deep into that one. This is the face bow system. We are installing that one. And then lower face bow. Yeah, looks dangerous, but it's not. Lower face bow system, you can see here, attached to the clutch. And then you put the so-called sensors. These one point to TMJ. Yeah? Now every motion here is moving here, one to one. If you make parallel the system, and you can, to a 1/10 of a millimeter, you can trace TMJ movements. Yeah? And then you have these. This is what it looks like. Yeah? Going back. Y-axis, left and right. And from the side, back and forth is x-axis, and up and down is z-axis. And you can see this scheme. Y-axis, Z and X. So you can evaluate by 1/10 of a millimeter. A standard protocol is protrusion, retrusion, open, close, medial protrusion left and right, and again here is why it is so important to have true hinge axis, because what we're tracing needs to be reproducible. If I trace one time here and one time there and one time there, the curve will look different and it will not be comparable and not be repeatable. So we need to check for the common hinge axis. And this is what you have been asking. No, who was with the rotation? It was you. Inside the software, we have one criteria you can evaluate between rotation and translation. There is a ratio. And usually, healthy joint, constantly in open close, same amount of translation and rotation. This one may be pathological. First only translation and then rotation. Something wrong. You know. You can evaluate with the software. Okay, open, close, medial protrusion. We trace the free movement. But most important, first we make the border movements. Open, close, protrusion, medial protrusion, left and right. But then we have to evaluate the functions. Patient has to speak with the apparatus. Count 51, 52, 53. S sounds and F sounds. 65, 60, or in your language. Make patient speak. Patient has to chew. So we can see, is there some loading to the joint or not? Does he have compensation? And of course, patient has to clench and grind and see what's happening in the joint. And then we can measure. And if there is more than 0.7, this way, or this way, we know when we look to our signs, sensitivity, yes, this TMJ is loaded by this and this and this function. And then we can change. And then we can, the patient must swallow. Yeah. Which is the most frequent function of mouth, is swallowing. Why is it so important? How many times swallowing per day? During the day, 1,500 times. Automatic function. You are producing 3 to 4 liters saliva, and you have to swallow, otherwise coming out. You don't want that. So automatic function is swallowing, plus food. And during nighttime, approximately 300 to 350 times during sleep, you're swallowing. What is happening?
Clench.
No, it's not clench. It's a strong thrust of closing muscles in the last phase of swallowing. When I swallow, the tongue goes up to the palate and pushes down liquid or food. At this time, the pharyngeal muscle, throat muscles, contract very quickly. And elevator muscles, this one and this one, very quickly, but very hard, close and go to occlusion. Must protect TMJ. If you see swallowing going up, something wrong. Constant malfunction. This is the vectors that is damaging ligaments of TMJ. Not one time, not 2 times, but 3-4 years problem function. If you have dental work, infraocclusion in molars, swallowing function will be compromised because molars not touching, right position, and every time patient swallowing, bong, 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 in the joint, 2,500 times per day. So you have to look at that. And impossible to evaluate only by clinical measure. Because no therapeutic consequence. If we want to treat the problem, we need to measure. Okay. Same. I have been explaining. Yeah. This is the mechanical version. Hinge axis point. As additional reference point, we're using orbital point because it's well researched that orbital point is very reproducible, especially in X-ray. And all articulators do use some kind of skeletal anterior reference point. So then, taking the face bow, individual hinge axis transfer. So after we measure the patient, then we mark hinge axis to skin. We mark this one. And now we can use this one as face bow. We can use this one as face bow. We take clutch for upper jaw in the patient and we can connect with face bow. This face bow now has geometric information about patient. Size, height, and depth of face. You have scales here. You know exactly the size of the patient. And you know exactly the position of hinge axis right and hinge axis left. It's inside the face ball now. And you have anterior reference point. Now you can take clutch and transfer 100% correct position of upper dentition to articulator. So articulator is same as patient now. Take this off. And very nice, we can transfer, if we put metal here, here and there, we can transfer these points to lateral cephalometric. So our reference plane, articulator reference plane, is in here. Now we can evaluate skeletal parameters towards the same. Now, this is seen. Of course, panoramic X-ray. This is the way I prefer to do a reference position. Yeah, very reproducible. What do you use?
For CLI,
Yeah.
I use like Dawson's method,
Okay.
but I use one hand. So as patient bite cotton front
Before, yeah. For deprogramming.
for deprogramming as well as CLI.
But which material do you use?
We call it
Silicone.
silicone.
Surgical. Okay. Yeah. And if you do 2 or 3 times after, is it always reproducible? Is it always the same?
I think so.
You think so? Don't tell your patients that you think so. This method is within the range of 0.02 reproducible. Our colleague, Elliot Uri, he did his master study on that one. One patient, 100 times, he did every morning. One of these. And then compare. Every time mounting. New model, mounting. 100 articulators. Same patient. Only 0.02 deviation. So highly reproducible. Highly reproducible. This is very important. I don't like silicone, but we can discuss later. I tell you why.
Well, I have to use silicone because I have to see the bite. Okay, and I ask patient to reproduce the same bite, and then the what do you call it? The molar shouldn't contact.
Of course.
Yes, that's why I use silicone. You can use that for me.
Yeah. If it works in your hand, no problem. Okay. Yeah. The lab procedure. This is the lab procedure for mounting. And then using the RP bite or whatever you use, you can transfer lower model. Then you can program articulator. For every millimeter of movement, you have a value. Now you can program articulator any which way you want. This is only one possibility. And how many articulators are in the software? Many. I think it's with the software, with our software we're using, you can program 20 different articulators, every brand. Dana, SRM, Artex reference, and so forth. Can you see? So, probably you know this one. Yeah? In a patient that needs treatment, sometimes we use so-called Rux checker. This is 0.1 millimeter thickness vacuum press foil with food color. And patient wears overnight. And you see bruxing pattern of patient. And you can confirm occlusogram from before. You can really see patient strong interference in molar. You can confirm. If you don't believe occlusogram, you can do this. Yeah? Okay. Very important why we need precise articulator mounting inside view. Most patient contacts here. You cannot see from outside. You cannot see clinically. You must have models. Okay, photo status. Sorry. Sorry. Now, we have joint tracing in the patient. Yeah. We have articulator mounting. We have definition of vertical dimension by cephalometrics, by lateral X-ray. We can measure. And now we can take silicone impression towards reference plane. And now we can measure inclination of teeth, and we can compare with joint. And then we can say, to steep guidance, tooth shape we must change, tooth position we must change, and so forth. Yeah. We can evaluate, we can measure. You saw the pictures of the study before when I was showing the degree of teeth inclination. This is how we do it. Yeah. We measure here and here and here. We cut the silicone, cut here, cut, and then this part of the silicone is reference plane. You can see here. This is parallel to reference plane. And you can compare these values with condylar path. And we can say this is interference or this is not interference. Another fact now. And we can measure so-called CPM. This is what we have been discussing before. Is there discrepancy between reference position and ICP, maximum intercuspation? Yeah. We can go to the models, we can make a dot, reference position, and we can make a dot ICP, and we can measure how much compression is in joint, or how much deviation. Okay. This is evaluation form for description of condylar movement. Yeah. We evaluate the quantity of movement, we evaluate the quality of movement, we evaluate the shape, the character of the curve, we evaluate symmetry, we evaluate transversal findings, delta y, for instance. We check for retrostability and, very important, reproducibility. See if the phenomenon is really there. Then there is evaluation of skeletal findings. We don't have to go too deep. Now we can transfer our reference position. We can implement joint tracing here. We can trace occlusal plane, and we can trace inclination of molars. And we can transfer that to the models. And now again, a mathematical fact we have. Red is prosthodontic occlusal plane from lower incisor to lower tooth number 6. And this is only tooth number 6, only tooth number 7. Yeah. So, and this is a very simple mathematical equation. If we have sagittal condylar inclination, sorry, N is German, it should be I, inclination. Occlusal plane is 28. The depth of the cusps is 31. If we combine that, so-called angle of this occlusion is minus 5. Minus 5 means teeth touch. They must touch. Impossible not to touch. This means posterior interference, hyperbalance, or lateral intrusive contact. Now we can confirm in this patient, when patient is grinding. Oh, sorry.
You mean it should be the same, the condyle diagram?
No, it should be positive, about 10 degrees for disclusion. Yeah. Patient is using these contacts, and by anatomy she must use, she cannot do different. Now we know, chewing, clenching, grinding and speaking, patient has molar contacts, but patient is avoiding those contacts. This is why muscle is so sensitive, and this is why there is load to the TMJ in this patient. Angle of disclusion. Yeah? Angle of disclusion should be around 10 degrees. Then it is sure no interference. So now we have kind of a clear plan for this patient. We know how much to change in molar region to get rid of interference.
10 degrees less than condyle. 10 degrees.
10 degrees. Angle of disclusion should be 10 degrees. I show you again. This one. This angle here should be around plus 10 degrees. So this means we have to change 15 degrees. Very difficult. Very difficult. Already now we know by crowns, impossible to change 15 degrees. This is clear decision. Impossible by prosthodontics to change this patient. If you make crowns only, you will fail. You cannot get rid of interference. Because if you try to make preparation of tooth number 7 and change 15 degrees, nothing left of tooth. Impossible. Just to make this equation clear, I make like a scheme on angle of disclusion. We try to make it very simple. This is tooth number 6, lower, tooth number 6, upper, class 2 relation, posterior, anterior. Okay? This is reference plane, and we assume sagittal condylar inclination 45 degrees, which is a regular mean value. Okay? So, here is the formula. Angle of disclusion is sagittal condylar inclination minus occlusal plane minus cusp inclination. So cusp inclination is this, which is the site that we can have interferences. For this example, occlusal plane is 0. Tooth number 6, very straight, very upright. This means sagittal condylar inclination minus occlusal plane is so-called relative condylar inclination, 45 degrees. Okay? Now, When mandible is moving, it's moving here with 45 degrees going forward and down. Yeah, it's inclined plane. Cusp inclination, 25 degrees, which is a regular cusp inclination. Nice fossa cusp relation. Yeah, 25 degrees. So, tooth will be moving this direction. Okay? This direction. This means going this way. And this discrepancy is angle of disclusion. We want a little space in between here, in the molar area, not to have interference. 10 degrees, because if patient is strongly pressing and grinding, there should be some space in between, not to touch the teeth. Yeah? So in this case, angle of disclusion is 20 degrees, which would be a little bit too much, but this is only an example. Now, we change, we make steep occlusal plane, 30 degree, just exaggerate. We stay with same 45 degree sagittal condylar inclination. We stay with cusp inclination 25 degree. Mandible is moving, but angle of disclusion in this case is -10. This means teeth must touch. We can only evaluate if we know posterior component. If we measure sagittal condylar inclination, we can judge this phenomenon, if it is physiologic tooth contact or not. Okay? Okay? So, I make a summary of this case, and then we go to practical part. Just 1 minute. So this patient has hypodivergent skeletal class 2. Deep bite situation. She has retruded mandible and retruded conducts. She has steep occlusal plane in the posterior area. No sufficient canine guidance in her case. 4 missing premolars. No posterior vertical support. And TMJ compression and injured and irritated joint capsule. All these problems we have to take care of if we want to sufficiently treat this patient. This is my team. That's me. It's my orthodontist, my prosthodontist, and my maxillofacial surgeon. This is team approach we have to do in this patient. Yeah. This patient said, if I do treatment, I want to get rid of my gaps. So I know I need orthodontists to open spaces. I need implantologists to put implants. I need prosthodontists to do crowns afterwards. So we have to make team discussion and make priority list when to do what to this patient. So our goal, this is what our Lego has to have for this patient. Increase vertical dimension, we need. We need to make posterior support in molars. We have to bring mandible forward in this patient because compression, too far retruded. We have to make flat occlusal plane in the posterior area, and we have to arrange the gaps of this patient. Okay? What we do is make a testing in the lab first, because this is very invasive treatment. It contains orthodontics, it contains implantology, and it contains full mouth restoration of the languages. We have to test if our conclusions are correct. So we make simulation, so-called wax up, set up, in articulator, in program articulator. This is my lab prescription, what I do. Do therapeutic wax up in this patient. Make protrusive position, make decompression of the joint, we can program and articulate. Raise incisal pin 4 millimeters. Arrange space for missing premolars, change occlusal plane, establish canine guidance, and then construct splint, oral splint in this therapeutic position. Yeah. So this is special articulator. We can simulate our position. So going forward, raising vertical dimension, unloading the joint, and then this is what the lab delivers to me. What do we have to do in the patient in metrical dimensions to change? You can see here. So occlusal plane has to be 5 degrees steeper. We have to retract central incisors. So you get a complete treatment plan by simulation of dental technician in articulate. Yeah. So this is what I do. And then I can discuss with the patient and ask the patient, do you want to do that? And this is the wax up of the patient. And then we produce this. I prefer to have lower jaw split, but could be upper one. And then 6 weeks after splint therapy, we can do re-evaluation of subjective signs and symptoms of patient and muscle palpation. And only little symptoms left, and muscle palpation strongly reduced, and joint sensitivity much better. This means we can go, and we can check clenching activity in patient on splint with new occlusal concept, only dynamic contact on canine. No posterior interference anymore. This is only RP contact.
What about anterior move?
Okay.
When it moves anterior, yes.
She's not using. This is nighttime wearing, only canine action, only lateral action. Okay, so therapy we will do later. Let's examine the patient. Okay? You need a break before we do that?
Just short break.
Okay.
5 minutes.
Können Sie Ihre Zähne aufeinander setzen ohne Probleme?
지금처럼 이렇게 딱 깨물었을 때 무슨 문제가 있었나요?
Ist der Biss immer gleich?
그 맞물리는 거, 깨무는 거 자체는 항상 똑같이 깨물리나요?
Ja. Sind Zähne auf Temperatur oder auf Druck empfindlich?
혹시 저기 치아가 그 온도에 민감하거나 깨물 때 좀 자극이 가거나 그러신가요? Eine Seite ist empfindlich.
Unten rechts.
아래 저기 오른쪽 아래 말하는 거죠?
네.
unten rechts.
Wann merkt sie das?
언제 그런 걸 느끼시나요?
빵 물 때요.
beim Kauen und beim
Beim Kaffee.
Kauen.
Beim Kauen. Immer beim Kauen.
그러니까 씹을 때 항상 그런 그쪽에 느껴지시는 건가요?
근데 가끔
가끔은 어느 정도 가끔?
아까 2, 3일에 한 번.
2, 3일에 한 번. 아까처럼 그 온도에 민감하고 한 거는요?
그것도 비슷해요.
온도에 민감한 거는 거의 항상 그러신가요?
아니 그것도 2, 3일에 한 번.
Ja, die bei uns 3 Tage.
Auch so. Okay. Und Temperatur oder nur Berührung?
Temperatur. 온도에 민감한 것도 지금 마찬가지죠?
네.
Ja,
Beides.
beim Kauen, beim Temperatur.
I write everything down. Ich schreibe alles auf.
지금 저는 얘기하고 있는 모든 것들을 지금 여기 인터뷰 그 포뮬러에다가 지금 적고 있습니다.
Ja. Und ich mache eine Bewertung mit Patienten zusammen.
자, 그리고 난 다음에 이제 환자에 대해서 충분한 모든 정보를 이제 이해를 하려고 하는 거죠.
Deshalb habe ich gefragt, wie oft hat sie
그렇기
Beschwerden?
때문에 항상 얼마나 자주 뭐 이런 질문들을 많이 하게 됩니다.
Ein Patient, der 2 bis 3 Mal in der Woche beim Kauen Schmerzen im Kiefergelenk hat und 2 bis 3 Mal die Woche empfindliche Zähne, ist immer eine Nummer 2.
지금 말기가 일주일에 2-3번 정도씩 씹을 때 아프고 또 그 온도에 민감하다고 얘기하는 거는 보통 저희 쓰기에는 그 플러스 2 정도를 예상을 하고 있습니다.
Haben Sie Probleme, den Mund weit zu öffnen?
입을 벌릴 때도 문제가 있으신가요?
No?
네. Nein.
여기가 좀 걸리는 느낌이 들어요.
Ja, vielleicht die letzte Seite ist ein bisschen klacken.
Ein Geräusch?
Ja.
Okay. Tut das weh, wenn das Geräusch kommt?
자, 입을 벌릴 때 아프신가요?
아프진 않아요.
Nein.
Nein.
Okay. Ein Geräusch,
자, 약간 소리가 나는 게 있고요.
kleine Störung im Gelenk,
야, 그리고
vielleicht,
조금 입을 벌릴 때 조금 이렇게 걸리는 느낌이 있을 거고요.
aber keine Schmerzen.
하지만 아프진 않습니다.
Grade 1.
이 정도면
네.
그레이드 1으로 칩니다.
Wann kommt das Geräusch? Bei ein bisschen Mundöffnung, Mittelmundöffnung oder weite Mundöffnung?
입이 걸리거나 소리가 나는 경우에는 입을 크게 벌릴 때 그러시나요? 아니면 조금 벌리려고 할 때 그러시나요? 어느 정도쯤에서?
벌리려고 할 때.
처음에 시작할 때 괜찮고
네.
크게 벌리려고 할 때
네.
막시멀 웨프는
Ja, weit. Terminales Knacken. Terminal Click.
터미널 클릭이라고 이제 지금 적고 있습니다.
Sie hat diese Frage schon beantwortet. Haben Sie Schmerzen in den Kiefergelenken? Hat sie vorher gesagt, das ist Ihr Problem? Ja.
처음에 첫 질문으로 턱 관절이 아프냐고 물어봤을 때 이제 그렇다고 대답을 하는 것으로 시작했습니다. 문제가 있는 거죠.
Jetzt fragen wir Patient direkt. 1 ist mild, 2 moderat, 3 schlimmes Problem. Wie schlimm ist dieser Schmerz für Sie?
자, 지금 턱이 아픈 게 좀 약간, 아니 중간, 아니면 심하다. 이렇게 세 가지로 표현했을 때 어느 정도라고
Wie
표현해요?
sehr stört Sie das mit dem Schmerz?
그러니까 그것 때문에 이렇게 통증 느껴지고 하는 게 어떻게 어느 정도로 느껴지세요? 생각하기에?
약간
mild, 1.
1. Hat sie Kopfschmerzen?
혹시 두통도 있으신가요? 야,
편두통.
편두통, 미그린.
Migraine. Which side?
어느 쪽?
Right side? Aha. Wie oft hat sie Kopfschmerzen?
얼마나 자주 두통이 생기시나요?
자주 있는데 일주일에 한 번 이상.
Einmal im Monat?
야, einmal in Woche.
Einmal in der Woche.
야,
Und muss sie Medikamente nehmen?
혹시 약을 드시고 계시나요?
Keine Medikamente.
약은 안 드시고요.
Wie schlimm sind die Kopfschmerzen im Vergleich mit dem Kiefergelenk?
자, 턱이 아픈 거 정도랑 비교해 볼 때 그 두통은 어느 정도신가요? 아까 약한 거, 중간, 심한 걸 볼 때?
그것도 약간
Schlimmer. 네, nicht schlimmer, mild.
Genauso.
Ja, genau so ähnlich.
Hat sie Verspannungen im Hals- und im Nackenbereich?
혹시 그 저기 목이나 어깨 쪽이 있어요?
Natürlich hat sie.
네, 그때 항상 이렇게 긴장감이 들고 그러나요?
네.
Ja.
야,
Immer
항상 그러신가요?
네.
야, 야,
vom Sitzen.
항상
Dental
앉아
assistant.
있고 하니까
Nurse.
네.
Schlimmer als die Kopfschmerzen.
좀 더 심하다고 생각하시나요? 그 두통보다? 야,
Hat sie Probleme mit der Körperhaltung? Hat sie anderswo am Körper?
어디 혹시 뭐 몸 전신 중에서 어디가 불편하신 데가 있으신가요?
Rückenschmerzen,
뭐 턱이
Beinschmerzen,
저기 허리가
Fußschmerzen,
아프시다던가 발이 아프시다던가 뭐
Hüftschmerzen.
턱이 저기 무릎이 아프시다던가 그
Nichts.
전신적인 데는 없고요.
Nichts. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9. 1, 2, 3, 4, 5, 6. 9 durch 6 ist 1,5. Ne?
야.
So,
이제 전체 9점 중에서 지금 6점으로 측정돼가지고 지금
Okklusionsindex 1,5.
오클루전 인덱스가 지금 1.5로 나왔습니다.
Subjectively, subjektiv, medizinisches Problem.
자, 환자 지금 같은 점수에 나오는 환자면은 이제 메디컬적으로 프로블렘이 있다고 볼 수가 있겠습니다.
Funktion des Kauens
자,
ist
기능적으로
kompromittiert.
교합에서 문제가 있고요.
Unsere Hauptfunktion, Ernährung, ist gestört.
자, 그거는 이제 우리가 이제 치료를 해야 될 부분에서 문제가 있다고 보는 것이죠.
Die Strukturen, Zähne sind empfindlich.
치아에 대한 부분은 좀 센시티브하다고 얘기를 했습니다.
Kiefergelenk macht Geräusch und tut weh.
자, 턱에서는 페인도 느끼고 또 소리도 난다고 했습니다.
Kopfschmerzen auf der gleichen Seite wie Gelenkproblem.
자, 두통됐다고 했는데 바로 턱이 아픈 쪽, 같은 쪽에서 두통이 있다고 했습니다.
Und Körperhaltung, schmerzhafte Verspannung.
예, 그리고 어깨 같은 데가 또 항상 긴장감이 있다고 얘기했고요.
Wir müssen Patient genauer untersuchen.
자, 이런 것들을 봤을 때 우리는 좀 정확하게 환자의 그 검사를 하게 된 것입니다.
Only nur 5 Minuten.
자, 5분,
Kurze Besprechung mit
자, 5분
Patienten.
만에 환자를 질문을 해서 그런 정보들을 얻어냈습니다.
Okay. Ein paar Merkfragen zur zahnärztlichen Geschichte.
자, 이제 치과적인 영역에서 조금 더 질문을 드리겠습니다.
Hat sie jemals einen Unfall mit Kopf-Hals-Beteiligung gehabt? Autounfall, Fahrradunfall, Skiunfall?
혹시 옛날에 한번 얼굴 쪽에서 다치신 적이 있나요? 뭐 운동을 하다가라든지 스키를 타다가라든지 자동차라든지.
Nein?
네, 없어요.
Nein.
Nein. Hat sie Operationen in Vollnarkose gehabt?
혹시 전신 질환, 전신 마취를 해보신 적이 있나요?
Nein. Was sagt uns das?
자, 지금 우리는 지금 상황에서는 어떻게 얘기를 하면 좋을까요?
No history, keine traumatische Vorgeschichte.
자, 히스토리적으로는 지금 전혀 문제가 없는 것으로 나왔고요.
Eine Frage noch.
자, 한 가지 질문을 더 드리겠습니다.
War Ihre Geburt normal oder gab es bei der Geburt Schwierigkeiten?
혹시 태어날 때 혹시 뭐 좀 어렵게 태어나셨나요? 어떻게 그랬지? 낙상이셨나? 아니면은 잘 쉬었게 나셨나요?
Warum frage ich?
순산이요.
뭐 말해?
Normal. Ja, warum
자,
fragen wir das?
왜 질문을 이런 질문 던지냐 하면은요.
Manchmal ist der Kopf zu groß und wird mit Zange geholt.
예, 그 감자로 집어서 빼야 되는 그 얼굴이 클 경우에 날 때 이제 감자를 집어서 빼기 때문에 그때 이제 트라우마가 갈 수도 있다는 얘기죠.
Very many times.
그래서 이제 이런 질문 던지게 됩니다.
Hat sie eine Zahnspange gehabt? Hat sie kieferorthopädische Behandlung
혹시
gehabt?
교정 치료를 한 적이 있나요?
Nein. Hat sie Zahnersatz?
혹시 뭐 치과 보철 치료를 한 게 있나요?
임플란트.
임플란트 하나 할수 있어요.
Wann ist das Implantat gesetzt worden?
언제 임플란트 치료를 받으셨나요?
작년.
letztes Jahr. 아니요.
Welches muss jetzt die nächste Frage sein?
자, 지금 이제 다음번 질문이 어떤 질문이 나와야 될까요? 다음 질문으로 어떤 질문이 나와야 될까요?
Was können wir jetzt schon schlussfolgern in unserem Kopf?
자, 이제 우리가 이제 마무리를 져야 될 텐데 머릿속에 어떤 생각을 가져야 될까요?
치료를 원하는지 원하지 않는지.
임플란트 Sie wollten behandeln lassen oder nicht?
Ja, das kommt gleich. Sie hat schon seit 2 oder 3 Jahren diese Beschwerden. Wie lange hat sie die Kopfschmerzen?
지금 머리가 아픈지는 얼마 정도나 된 것 같아요?
두통이요?
두통은 아까 이 턱은 한 2, 3년 됐다 그랬는데
두통도 꽤
야, fast ähnliche gleich.
Aufgelernt. Wie alt ist die junge Dame?
몇 살이시죠?
32이요.
32.
32. Okay. Erste Schlussfolgerung jetzt schon ist
자, 이제 마지막 질문은요.
chronisches Problem.
크로니시스?
Chronisches Problem. Langes Problem. Viele Jahre schon Problem.
좀 오랫동안 크로니카라는 문제로 이제 온 거라는 얘기죠.
Hat sie jemals eine Aufbissschiene gehabt?
혹시 스플린트를 껴보신 적이 있나요?
없어요.
Nein. Beißt sie fest auf die Zähne? Knirscht sie mit den Zähnen?
이렇게 세게 꽉 깨무는 그런 습관이 갖고 계신가요?
Ja.
야.
Of course. Asian. Denkt sie, dass eine Behandlung notwendig ist?
자, 본인이 느끼시기에 치료가 필요하다고 느끼시나요?
네.
야.
Vermutet sie eine schwere Erkrankung?
본인이 느끼시기에 이게 아주 심각한 병이라고 생각하시나요?
네.
야.
Yeah. We have to be very careful.
자, 이럴 때는 굉장히 조심을 하셔야 됩니다.
Okay. Wo haben wir das eine Blatt, das Schmerzschema? Ja, ist okay. Bitte helfen Sie mir.
자, 여기 한번 저 좀 도와주세요.
Schmerzen hier.
자, 여기 거기가 아프다고 그러셨죠?
Wo sind die Kopfschmerzen?
자, 어디쯤이 머리가 아프세요?
Wo sind die Kopfschmerzen? Da.
자, 거기쯤에 머리가 아프시고.
Wir markieren auf dem Schema.
자, 여기
야.
지금 스캔에다가 이제 마킹을 하고 있습니다.
Wo sind die Nackenverspannungen?
자, 어깨랑 목 중에 어느 쪽이 주로
Auch
아프세요?
rechte Seite? Ah, echt?
자, 그리고 같이 오른쪽에 계속
야.
같은 부위가 아프시고요.
Da? Rechte Seite.
네.
Okay? Da.
자, 좀 오른쪽으로 지금 편중돼서 지금 아프고 있습니다.
Andere Stellen am Körper, dass sie
Ja.
Schmerzen hat.
자, 혹시 다른 부위에 온몸의 다른 부위 쪽에 혹시 아프신 데가 있나요?
Nein.
다른 데는 없고요.
Okay. Kann sie alles riechen?
리힌.
Riechen, ja. Ist ihr Geruchssinn in Ordnung?
코 냄새 맡고 하는 것들 다 문제 없으신가요?
Okay. This is neurologic screening, neurologisches Screening.
예, 뉴럴로지컬한 스크리닝을 하고 있습니다.
Erster Riechnerv.
자, 제일 처음엔 이제 코에서 냄새 나는 걸.
Wie sind Ihre Augen? Braucht sie
자,
eine Brille?
눈은 어떤가요? 눈 좋으신가요?
Hat sie eine Brille?
저 안경 끼시나요 혹시?
Nein.
안경은 안 끼시고요. Nein, keine
Braucht keine
Brille.
Brille. Okay. Zweiter Nerv, Sehnerv.
이제 보는 신경에 대한 부분을 얘기를 하고 있습니다.
Wie ist Ihr Gleichgewicht?
지금 그 몸무게가 같으신 유지가 되시나요?
Kann sie gut Gleichgewicht halten?
Ja.
Okay. Achtnerv. Okay. Oh, great. Now, objective examination. Muscle and joint palpation.
자, 이제 머슬하고
아.
조인트 쪽에 이제 팔페이션을 합니다.
Okay. Ich nehme zuerst die rechte Hand von der Patientin.
자, 제일 처음에는 이제 오른손 환자의 오른손을 잡았고요. 링스.
Egal, egal.
한쪽 손을 잡았습니다.
Das hier, keine Angst.
자,
Das hier
편안하게
ist
하시고.
normalerweise ein Muskel, der nicht wehtut.
자, 일반적으로 저런 집었을 때 이제 머슬이 아픈 통증을 느끼지 않습니다.
Tut das weh?
아프세요?
Nein.
Ja.
Okay. Mit dieser Kraft
자, 지금 정도의 힘으로
taste ich gleich
그 옆에를
예,
똑같은
무슨-
그 정도의 힘을 아마 눌러보겠습니다.
zum Vergleich.
자, 그거랑 같은 힘 정도를 누르겠습니다.
Tut das weh?
지금 아프세요?
Nein.
아니요.
Mit dieser Kraft
자,
taste
똑같은
ich gleich
힘으로
das
다시
Gelenk.
한번
오케이.
턱에서도 맞춰보겠습니다.
So, okay. Please
릴렉스.
now relax, but take off the coat. I need
이거 코트 벗어주시겠어요?
no, only coat. Only coat. Please don't do in office like this. No, don't. Okay, go ahead. So, we start first. Erst ist.
처음 시작은요.
Pass auf, ich mache das an die Wand. Ich mache das Schema an die Wand. Okay? Das rechte Schema jetzt. Das
자, 지금
erste,
이제 오른쪽에 있는 그 포뮬라를
Schulter, Nacken.
합니다.
Okay?
어깨부터 보고요. 어깨와 목을 보겠습니다.
Sie soll mir bitte sagen, unangenehm, schmerzhaft oder links und rechts unterschiedlich.
자, 처음에 좀 불편하다, 그리고 아프다, 그리고 오른쪽 왼쪽이 다르다. 그렇게 세 가지 중에서 표현을 해주세요.
Es ist empfehlenswert, vor dem Patienten zu sitzen.
자, 항상 지금처럼 환자의 정면에서 앉아서 검사를 하게 됩니다.
Ich kann in die Augen, keine Angst, ich kann in die Augen gucken.
아, 그리고 눈을 바라봅니다.
Ich sehe, ob schmerzhaft oder unangenehm.
그러면은 환자가 지금 아파하는지 불편한 정도인지도 같이 체크를 하게 됩니다.
Rechts schmerzhaft,
오른쪽 아프신가요?
really?
거기.
자,
Ouch.
야.
Rechts 2.
자, 오른쪽이 이 정도 그레이드를 갖고요.
Nochmal.
자, 한 번만 더 해보겠습니다.
Ich drücke mit dieser Kraft.
자, 한 번 더 똑같은 힘으로 한번 손을 눌러보고요.
Wenn es irgendwo unangenehmer ist oder schmerzhaft, sollen Sie mir Bescheid sagen.
자, 어디가 불편하거나 아프면은 항상 그 정도 힘으로 누르고
오케이.
있으니까 아프면 말씀하세요.
No? Auch.
거기 또 아프. 야, 나인.
Nicht. Okay. Atlanto-Occipital, zweiter Muskel.
자, 지금 두 번째 머슬에 대한 부분을 말하고 체크합니다.
Aua. Tell me.
자, 아프시면 아프다고 얘기를 하세요.
Aua.
아우아가 아야예요.
Au. Ouch. Ja.
아우치. 괜찮으세요?
네, 괜찮아요.
오케이.
Okay. Nächster. Temporalis. Nichts, nein. Also rechts 2 beim Schulter. Ne? Okay.
다음 세 번째입니다.
Nein, okay. Bite.
자, 깨물어 보세요.
Stop.
예,
Okay.
하시고요.
Musculus temporalis anteriorer Anteil.
예, 알아들으셨죠?
Kein Aua. Mittlerer Anteil
자, 밑을 중간
und hinterer Anteil.
포스테리얼
Kein Aua.
파트하고
오케이.
미드런
Nächster. 4a.
네 번째
Masseter.
마세터 머슬 쪽입니다.
Oberflächlicher Teil.
표면 쪽이고요.
Aua.
아프세요?
Nein. Autsch.
야, 그쪽 아프시고요.
Masseter rechts oberflächlich 2.
자, 마세터 머슬의 표면 쪽을 지금 그레이드 2로 잡았습니다.
Jetzt tiefer Anteil vom Masseter.
자, 이번에는 깊숙한 마세터 머슬의 안쪽을 보겠습니다.
Ja.
디포지션입니다.
Sie sagt Schmerz. Sie soll sich melden. Sie soll sagen Aua.
아프면은 그냥 아 소리를 내세요.
Sonst taste ich viel zu lange. Rechts
안
tiefer
그러면은
Masseter 2.
계속 오래 만져야 되니까 바로 얘기를 해주세요.
Linker Masseter 1. Tiefer linker Masseter 1.
왼쪽에 디포지션 쪽에서 스페인 1 정도를 느꼈습니다.
Jetzt gehe ich. Tuber maxilla ist
Tuber maxilla
Pterygoideus lateralis.
자,
Wir müssen jetzt intraoral tasten.
자, 이제 입안 쪽으로 해서 검사를 하게 됩니다.
Open, yes. Open a little bit.
자, 조금 더 입 벌려주시고요.
Close.
자, 조금 다
Stop,
잡으세요.
no, little bit, sir.
네, 조금만요.
Ouch.
거기가 아프셨어요.
Links 2.
자, 왼쪽 2,
아우.
Rechts 3. Sorry.
오른쪽은
Yeah,
3.
please remember.
다시
Only,
한번 기억해 보세요.
only this.
자, 지금 저 정도 힘으로 이제
I only do
눌렀는데
this. She said, oh, she's stabbing me now. Medialer pterygoid.
자, 메달은 테리고이드 머슬입니다.
Kannst du bitte noch aufschreiben? Na, machen wir nachher. Aua.
지금도 아프시다고 그러셔서
Rechts medialis 2,
왼쪽 메달리스는
links
2,
1.
오른쪽은 1입니다.
Nächster, Mylohyoideus. Mundbogen.
마일로 하이드 머슬입니다.
Rechts 3.
오른쪽 3.
Wann immer sie mir sagt, es tut weh, bin ich sofort weg. Sie soll sich schnell melden, ja? Also
아프면은
Mylohyoideus rechts,
얘기하시면은
alles
뛸
ankreuzen.
테니까요.
Links 2.
겁먹지 마시고.
Digastricus, Nummer 8.
다이가스트릭 머슬입니다.
Ouch, rechts. Ouch, links. Ja, 2, 2.
자, 양쪽 다 2씩입니다.
So, nächster, suprahyal ist
다음은 스프라 하이드
floor of the mouth.
자, 밑에 저기 그 플로어 쪽이죠. 마우스의 플로어 쪽입니다.
Uncomfortable.
괜찮으세요?
조금 불편한 정도.
비슷비슷한
Ein bisschen unangenehm. Beidseits 1 beim Suprahyal.
1로 작았고요.
Jetzt prüfen wir Infrahyal, das Zungenbein.
자, 이 인프라헤드달 머스 쪽입니다. 이제 혀 있는 쪽이죠. 괜찮으세요?
Okay.
오케이.
Wir prüfen Larynx.
자, 라링스 쪽을 또 보겠습니다.
Okay. Sternocleido mastoideus.
스테노클로이드 마스토이드 머슬이고요.
This one. Ouch.